I think we are ready to start. So it's my great pleasure to welcome you on behalf of all the ERN-EuroBloodNet, so the European Reference Network on Rare Hematological Disease. And so today we are at our 13th session of the topic on focus on thrombotic microangiopathies webinar for health professionals. As you may know, this program has been created by a collaboration between the ERN-EuroBloodNet and the French National Center for Thrombotic Microangiopathies, the CNR-MAT. And it consists of 15 sessions, and the program is accredited by 11 continuing medical educational point issued by the European Board for Accreditation in Hematology. So some house rules for getting those credits is that you have insert your correct and fully name and surname in the Zoom platform. And also you answer at the end of the session, you are going to receive a questionnaire, a satisfaction questionnaires, and it's made of 3 simply questions. So if you could answer, it's also a way for us for tracking your presence and giving credits. Other simple technical information before starting is that this session is recorded because it will be implemented in our e-learning platform and in our also educational YouTube channel. So if you don't feel comfortable with camera of being registered, so please put your camera off, and also your microphone is muted. And if you have any question, as we hope, about the presentation, please write them in the chat. So there will be at the end of the presentation a Q&A session, specific session. So those questions will be addressed at that moment. So dear audience, now please welcome with me the speaker of today's lecture, so the Professor Fadi Fakhouri, who will lead a lecture on pregnancy-associated hemolytic uremic syndrome. Professor Fakhouri is an adult nephrologist and a clinical researcher. He has a long-standing interest in autoimmune renal diseases, particularly complement-mediated nephropathies. He has conducted several clinical and experimental studies in the field of thrombotic microangiopathies, C3 glomerulopathy, and other membranoproliferative glomerulonephritis. So please, Professor Fakhouri, the floor is to you. Thank you very much.
Thank you, and thank you for the invitation, and thanks to the EuroBloodNet. So the topic of today is pregnancy-associated hemolytic uremic syndrome. These are my conflict of interest. These are globally the objectives of these seminars. And I will start now my presentation. So as you know, pregnancy and postpartum, because we tend to forget postpartum, are high-risk periods for several types of microangiopathies. Starting with TTP, of course, HUS, but also more frequent disorders like preeclampsia or HELLP syndrome. They have that both of them have several features of TMA, and they may be classified as TMA-like disease. But the spectrum extends, of course, to autoimmune-associated TMA triggered by pregnancy, and even postpartum severe bleeding may lead to some features of TMA, as we will discuss later. The interest in pregnancy and TMA has obviously been renewed by the discoveries around atypical complement-mediated HUS and this long story of translational research that led from a rare, severe renal and hematological disease called atypical HUS that has been the focus of intense clinical, genetic, and basic research, and that has led to the design and the use of a specific treatment. And this very successful translational research has renewed the interest in pregnancy TMA, but also put a lot of pressure on physicians attending these patients to recognize complement-mediated HUS and treated it accordingly. And of course, now it is assumed that complement-mediated atypical HUS is due to complement-induced damage to the endothelial cells. And this arises from dysregulation of the complement alternative pathway, whether you lose the inhibitory effect of several inhibitors like factor H, factor I, or MCP, or you have complement gene variants, activating variants in C3 gene and factor B gene, the two main components of the C3 alternative pathway. On one side, you have inactivating mutation inhibitors. On the other side, you have activating mutations or variants in two main components of the C3 convertase, alternative C3 convertase. And all of this leads to uncontrolled complement alternative pathway activation, which upon a trigger, mainly infectious trigger, may lead to endothelial cells induced complement damage, leading to thrombosis and subsequently to TMA. And of course, once you have discovered that this disease is related to an overactivation of complement inhibition, maybe C5 blockade, has changed the approach to complement-mediated HUS. Based on these findings, we tried with others to reclassify and restudy and reconsider the spectrum of complement-mediated TMA and complement-mediated HUS. And of course, as you know, pregnancy and postpartum are characterized by activation of complement, especially in the first and the third trimester. And in the absence of a tight control of complement regulation, you have a loss of pregnancy as outlined by several experimental animal studies. And this has led to studies to determine where in the spectrum of complement-mediated HUS should we classify pregnancy and postpartum HUS. This is one of the largest studies done in 3 European countries: France, UK with David Cavanagh's group, and Italy with Marina Norris and Beppe Rimuti's group, that included 87 patients clinically classified as having pregnancy or postpartum related hemolytic uremic syndrome without overt severe preeclampsia, eclampsia, and HELLP syndrome. This is just a precision before going further. The first learning is that the majority of cases of pregnancy related HUS occur in the postpartum or in the early peripartum period, very rarely during pregnancy by itself. But it has shown, this study has shown that pregnancy and postpartum HUS remains a very severe disease, with 70% of patients requiring dialysis and a significant number of patients, as you will see, who reach end-stage disease after just one episode of HUS triggered by pregnancy. This was the first learning we had from this study. The second is we realized that pregnancy and postpartum HUS had the same clinical severity in terms of renal outcome as any complement-mediated HUS not related to pregnancy. For example, the risk of end-stage disease within 3 months of pregnancy, 30%, equivalent, similar if not higher than normal outside pregnancy-related, not pregnancy-related complement-mediated HUS, and a significant number of relapses, including after renal transplantation, like any complement-mediated HUS, and 56% of these patients had one or several rare complement gene variants, like any complement-mediated HUS outside brackets. So this was a picture of complement pregnancy and postpartum HUS, very similar in terms of clinical presentation, outcome, and genetic risk factors as any complement-mediated HUS not related to pregnancy. And you have similar findings from a Spanish retrospective studies showing predominance of the postpartum, severity of the disease, and the same frequency, more or less 40% of complement gene rare variants in these patients. So based on these findings, the pregnancy and postpartum HUS has been reclassified and put inside the spectrum of complement-mediated atypical HUS. And this had very significant implication for patients, because as you know, anti-C5 treatment, mainly eculizumab, ravulizumab, or other anti-C5 drugs in development, has radically changed the renal prognosis of atypical complement-mediated HUS. And you have limited data regarding the use of eculizumab and anti-C5 treatment, specifically in patients with pregnancy and postpartum HUS. We have this retrospective study from Spain showing a really better renal prognosis with eculizumab compared to no eculizumab in patients with pregnancy and postpartum HUS. And this is a review of individual cases we did recently with the working group on pregnancy and postpartum TMA, showing the same trend of an excellent response in terms of hematological remission, but also, and the most importantly, in terms of renal function recovery with eculizumab in pregnancy and postpartum TMA. Two points have to be addressed. The first is that the treatment of pregnancy HUS, complement-mediated HUS occurring during pregnancy, have some peculiarities, mainly in the use and the dosage of anti-C5 treatment during this period, due to the increase in the volume of distribution, probably also to an increase in C5 synthesis during pregnancy. You need more anti-C5 drugs to inhibit C5 activation during pregnancy. So you need higher doses of eculizumab and more frequent, which means shorter intervals between infusion, to maintain an optimal complement inhibition, which is usually illustrated by CH50 below 20 or 10%. This is the first point. The second point is that in patients with atypical HUS, treated preventatively, prophylactically, or treated curatively for HUS during pregnancy, anti-C5 treatment is not a guarantee against the occurrence of preeclampsia, eclampsia, and HELLP syndrome, which is an indirect argument saying that preeclampsia and eclampsia do not have, in these disorders, the role of complement dysregulation and activation is not so tremendous as in atypical HUS. So, based on all this data, it may seem very simple to say that this HUS is related to pregnancy and postpartum and should be treated with eculizumab or any other anti-C5 treatment. The problem is, as already said, the number of disorders that may mimic HUS in pregnancy and postpartum is very important, and especially you have a lot of disorders like preeclampsia or HELLP syndrome that they are by far more frequent than HUS or TTP. So problem is in pregnancy and postpartum, and even outside pregnancy and postpartum, we do not have a positive diagnostic test for complement-mediated HUS to say that this is a TMA mediated by complement. It's a problem outside pregnancy, but this problem is more crucial during pregnancy. The problem is the usual features of complement activation, let's say low C3 or low CH50, are not very reliable. You may have a very clear-cut complement-mediated HUS with a clear-cut pathogenic rare variant and have normal C3 and normal factor H value. And even more specific markers like C5b9, soluble C5b9, circulating and product of complement activation are not reliable. And you have a huge overlap between normals, patients with no complement-mediated TMA and complement-mediated HUS, which means that the usual complement assays are not very useful in the clinical setting. That's why several groups have developed in vitro tests, especially Marina Norris group and Remedi's group, and also the Spanish groups. In few words, you take a patient serum, you deposit it on, you incubate endothelial cells in vitro with the serum or plasma, and you see if you have deposition of complement products, C3b and C5b9 on endothelial cells. And the hypothesis is that if you have increased complement deposition at the surface of endothelial cells, you may presume that it is a TMA mediated by complement. The problem is these tests have not been replicated in several laboratories and need to be replicated, tested, and standardized. And in my point of view, as they are not fully ready to be used in a clinical setting. That's why we set up an expert group of nephrologists, hematologists, obstetricians, and neonatal medicine experts to give some guidance around TMAs occurrence in pregnancy and postpartum. It has been recently published in Blood, so it is available. And we gave some very simple messages. They may seem very simple, but they merit some to be repeated, and clinicians be reminded of this very simple thing. For example, the context preeclampsia, eclampsia, HELP syndrome. If you have a typical preeclampsia, do not try to find a very rare disease when you have a very obvious disease already present and clinically evident. The second point is that you have to keep in mind that atypical HUS and TTP are very rare disorders in general and during pregnancy in particular, which means you have much higher probability to have preeclampsia, eclampsia, or HELP syndrome than having HUS and TTP. Once again, there is no positive diagnostic test for HUS, which means it remains an exclusion diagnosis, and we'll come back to this point a little bit later. The fourth point is that increased level of serum liver enzymes are extremely rare in atypical HUS. Very significant increase in liver enzymes above 10, 12 times the upper limit of normal are not very suggestive of atypical HUS. Another point that remains to be repeated is that the benefit of plasma exchange is only proven in immune ADAMTS13 deficiency related TTP. As you know, this is a very stressful condition and setting when you have a pregnant patient or patient who has just delivered a baby, a newborn, severe TMA, acute kidney injury, very severe thrombocytopenia, and we fear the need to do something. But one have to be reminded that when we do plasma exchange, the benefit is proven only when you have anti-ADAMTS13 inhibitory antibodies. In all other settings, starting with complement-mediated HUS, preeclampsia, and eclampsia, plasma exchange are probably more harmful than the opposite. So, based on these simple messages, we tried to do and to give some recommendation for the diagnosis and the treatment of pregnancy and postpartum TMA. So this seems very complex, but unfortunately, life is sometimes very complex. But I try to simplify. When you have TMA in pregnancy, of course, you take into account the context, blood pressure, proteinuria, liver enzymes, but also more and more increasingly, you take into account soluble FLT1 PLGF ratio, and this ratio has not been validated in the setting of TMAs or TMAs-like disorders other than preeclampsia and eclampsia. But still, it seems to the experts reliable to rely on this parameter to go in the direction of preeclampsia, eclampsia, and HELP syndrome. The second point is, of course, testing for ADAMTS13 and anti-ADAMTS13 antibodies, like in any TMA. Take into account coagulation parameters. For example, disseminated intravascular coagulation is not suggestive of TMA. Usually, pure TMA, you do not have very significant disturbances of prothrombin time, factor VIII, fibrinogen, or D-dimers level. And of course, keep an eye on some autoimmune disorders, starting with lupus and antiphospholipid syndrome. And once you have excluded all these disorders, you are left with the diagnosis of complement-mediated primary HUS triggered by pregnancy or postpartum, but it remains once again an exclusion criteria, which means that sometimes you start a treatment when you have a reasonable probability that is not the other diagnosis, and you have to assume that you have a margin of error of 10–15% because you have no reliable diagnostic test. Of course, you have to do all the complement assays and screen, genetic screenings and complement gene, but you can't rely on these parameters to diagnose complement-mediated atypical HUS triggered by pregnancy and postpartum. And we have also tried to give some guidance for the treatment. And I will try to simplify it. The first message was, in the absence of cardiac and severe neurological involvement, putting aside PRESS syndrome, which is more related to hypertension than TMA by itself, but whatever. If you don't have a very severe cardiac and neurological involvement, close monitoring during 24–72 hours is advised in order to rule out other more simple diagnoses like sepsis, autoimmune disease, or postpartum bleeding. I'll go back to this feature a little bit, this condition a little bit later, and to give time to the clinician and the patient to see how hematological parameters and renal parameters will evolve. If you have a spontaneous improvement in platelet count, hemolysis, and serum creatinine, HUS and TTP are unlikely, and you continue monitoring. Otherwise, you start plasma exchange with fresh frozen plasma only for the provision that it may be ADAMTS13 deficiency due to autoantibodies in the setting of TTP. This is why we start plasma exchanges, because we don't want to miss the treatment or delay the treatment of TTP. And of course, you continue the treatment depending on the result of ADAMTS13 activity. Just one word about postpartum hemorrhage. I will discuss this in detail a little bit later, but this is a very significant point to have in mind because it may lead to an excess treatment of plasma exchange or other complement inhibitory treatment. And once you have excluded all the diagnoses, and including ADAMTS13 deficiency, you are left with pregnancy and postpartum triggered HUS, and you start anti-C5 therapy. And we will see a little bit later for how long you start treatment. So one word about severe postpartum hemorrhage and renal cortical necrosis. As you know, renal cortical necrosis has more or less disappeared, at least in high-income countries, since the legalization of abortion, no septic abortions, and no more septic abortions. But we had a small epidemics in France reported by Marie Frima and co-workers a couple of years ago, of patients with postpartum severe bleeding that presented with features of very severe TMA, most of them requiring dialysis, severe thrombocytopenia, in the setting, of course, of a huge loss of blood volume and the use of fibrinogen, a lot of platelets transfusion, but also tranexamic acid, an antifibrinolytic that has transformed and improved radically the prognosis of women with severe postpartum. And renal cortical necrosis is some sort of ischemic infarction of the renal cortex that is irreversible. And it is due to massive clotting in the cortex of the renal parenchyma, where are located the glomeruli, the filtration units of blood. And in this study, it was the use and the duration of tranexamic acid that was associated to an increased risk of occurrence of renal cortical necrosis, but also to less good quality or less worse renal outcome, which means that the patient who received longer duration of tranexamic acid had a worse renal outcome. And this has triggered a discussion about the spectrum, where does this renal cortical necrosis due to severe postpartum bleeding belong? Does it belong to the spectrum of complement mediated? To date, we have no indication that the patient have a higher incidence of complement gene variants compared to healthy individuals. One word about healthy individuals. If you take a healthy population, you have around 5% of healthy individuals who have complement rare variants. And when you speak about complement rare variants, not all of them are pathogenic, and you need the expertise of experts of genetics and complement biology like Véronique Framobaki, Marina Norris, David Cabana, who can tell you whether this variant is pathogenic or not. So in the meantime, I don't think that renal cortical necrosis is to be treated by complement inhibition. It's a severe disorder due more to coagulation and clotting than to endothelial cell damage. It doesn't mean that the very peculiar situation and status of the endothelial cells during pregnancy, because as you know, pregnancy is an anti-angiogenic state due to the increase in soluble FLT1, which make probably the renal endothelial cells more susceptible to ischemia. That's why virtually the only situation in which nephrologists in high-income countries still see renal cortical necrosis is severe postpartum bleeding. So this was the treatment, but the availability of this new anti-C5 drugs has opened a new perspective for patients with a history of atypical HUS and who wish to start a new practice. 10, 15 years ago, probably most nephrologists would have contraindicated or advised against pregnancy. It's no longer the case. Pregnancy is no longer contraindicated or advised against in patients with a history of complement-mediated atypical HUS. Why? Because for two reasons. First, the risk of relapse during the further pregnancy is highly unpredictable. You may have a patient who have 5 pregnancies, uneventful. The 6th one, she develops atypical HUS. And you may have a patient who had very severe pregnancy atypical HUS and who have 2 further pregnancies with no recurrence. This is the first point. The second point is that we now have available a new efficacious treatment. We didn't have such a treatment 10 or 15 years ago, which means that we did not advise in the conference consensus group, we did not advise for prophylactic use of eculizumab in these patients. But we advised a very close monitoring and restart of eculizumab or start of eculizumab in case of early signs of TMA during pregnancy or postpartum. These patients may have, in contrast to other patients, this patient with a history of ATP HUS probably have a high risk to develop TMA and HUS rather early in further pregnancy. So close monitoring as early as pregnancy develops. The second point is, for how long should we treat patients with postpartum HUS and pregnant HUS who have received anti-C5 treatment? We have no study that has addressed this point specifically in patients with pregnancy and postpartum HUS. But we have data generated from a respective series and from one prospective series we did in France with Fadi Fakhouri, Chantal Waha, and other researchers listed here on the slide. In this study, adults and patients and children who were on eculizumab for ATP HUS were discontinued, and we evaluated the risk of relapse. These are the main findings of the study. Among roughly, we had 55 patients, only 13 relapsed, and 12 among the 13 had complement pathogenic variants, mostly MCP variants, especially in children. All of them were retreated, and all of them regained their baseline renal function with no additional renal damage, except two patients. The first here, who had an MCP, who had a history of repeated episodes of HUS relapses, who had a very significant CKD, who relapsed. He did not regain his initial renal function. He was retreated despite retreatment. He discontinued once again, did another relapse, and progressed to dialysis. And the second patient here is a patient who had some delay in the diagnosis of her relapse of ATP HUS because she had only proteinuria as a single sign, at least in the initial phase of her relapse. And to make a long story short, the main predictor of relapse was the presence or absence of complement gene variant. If you have no complement gene variant in adult here, your probability of relapse is 0%. This is in children, in blue, patient with no complement gene variant detected, only one relapse. I don't know if I have, no, I don't. I'll go back to this patient a little bit later. But this presence or absence of complement gene variants are to date the best predictor of relapse after eculizumab discontinuation. And in this study, we did multivariable analysis with a very limited number of patients, of course, but we did what we could do with this limited number of patients. And the complement gene variant was still the most predominant predictive factor of relapse after ATP HUS, after eculizumab discontinuation. The second one, we had the surprise with Fadi Fakhouri, who did all the assays, to see that soluble C5b9 at the time of eculizumab discontinuation is also predictive of HUS relapse after eculizumab discontinuation, especially in patients with complement gene variants. Why patients have still detectable C5b9 under C5 blockade? The question is not fully answered. Probably they are activated by other factors and other enzymes independent of C5 convertase, especially if you have a high density of C3b at the surface of a cell. Probably you will activate C5 even if you have an inhibition of the activation of C5 by the C5 convertase, classical C5 convertase. There are some also studies pointing for a role of thrombin in the activation of C5 independently of C5 convertase. So at least in our study, complement gene variant, one factor, and soluble C5b9, if it's still higher than the normal at the time of eculizumab discontinuation, it is also predictive of atypical HUS relapse after discontinuation. So we are moving more or less towards a consensus for accidental discontinuation, including in patients with atypical HUS triggered by pregnancy and postpartum. The risk of relapse in all retrospective studies, if you have no complement gene variant, is below 5%. 2 exceptions in all the reported cases, 1 exception in our series, in our prospective study, a child. We are very suspicious of this story, and it turned out this patient did not have atypical HUS. He had ADAMTS13 deficiency, constitutional ADAMTS13 deficiency that has not been diagnosed beforehand. And when we tested ADAMTS13, when the clinician in charge of the patient tested ADAMTS13, it was undetectable, and the diagnosis of atypical HUS was ruled out. The second patient had secondary HUS in an American series where secondary HUS are mixed sometimes with primary pure complement-mediated atypical HUS. So, in conclusion, pregnancy and postpartum HUS is a complement-mediated atypical HUS. There's more or less a consensus about this question. So, problem is that to say whether it is atypical HUS or not in the setting of pregnancy and postpartum is sometimes very challenging, but it is a very challenging and urgent question because a specific urgent treatment is required. And this is the availability of all these new complement modulators have changed the approach to these disorders and of TMA triggered by pregnancy and postpartum. Discontinuation of C5 blockade is feasible in some patients with pregnancy and postpartum atypical HUS, like in any patients with complement-mediated atypical HUS, meaning that patients with no detectable pathogenic complement gene variant can probably safely discontinue treatment with anti-C5 drugs. And the last point is that pregnancy in a patient with a history of atypical HUS is no more contraindicated, but remains a high-risk pregnancy. For 2 reasons: risk of relapse of atypical HUS, which means you need multidisciplinary monitoring throughout the pregnancy and up to 3-4 months postpartum. And the second point is that the residual CKD, or at least kidney injury, whether it is clinical or subclinical, is sometimes a more major problem in pregnancy in these patients in terms of preeclampsia, eclampsia, prematurity than the risk of relapse of atypical HUS. This is what I had to present today, and I would be more than happy to answer your question if you have questions.
Thank you very much, Professor Fakhouri, for your exhaustive presentation. So now I ask the audience if they have any question to share. So please write them in the chat. This is the occasion to direct us to the expert, clarifications, doubt, or any other kind of comment, feedback, etc.